Imagine waking up one day and discovering that a part of your own anatomy is slowly, quietly erasing itself.
It sounds completely impossible, right? Like something made up.
Right, yeah. It sounds like a concept pulled straight out of, like, science fiction, or maybe a bizarre body horror movie. But today, we're actually looking at a medical reality that does exactly that.
We really are.
We're asking a highly specific, obviously startling question. Can a skin condition called lichen sclerosus actually cause the labia minora to resorb, or essentially to just disappear entirely?
It's a profound question. I mean, and answering it really requires us to look very closely at the mechanics of human tissue and how the body systems can sometimes turn against themselves.
Yeah.
Now, we are discussing highly sensitive anatomy today, but understanding the biological why behind these intense physical changes is just so essential.
So it removes the taboo, right?
Exactly. It strips away the stigma and empowers you to understand exactly how resilient and sometimes, well, how fragile our biology really is.
So we've been pulling from a massive stack of medical literature to figure this out for you today. We've got clinical guidelines from the British Association of Dermatologists.
The BASH guidelines, too.
Yeah, the BASH guidelines, plus data from the Mayo Clinic, Yale Medicine, and a bunch of specialized vulvovaginal disorder clinics. And looking at the timeline in these clinical guidelines, I immediately noticed a pattern.
Mm-hmm. The age spikes.
Right. The onset of this condition, lichen sclerosus, or LS, seems to spike primarily in prepubertal girls and then again in postmenopausal women. So my first instinct, seeing those two demographics, is that this has to be driven by massive drops in estrogen.
And that is exactly where most people's minds go. And frankly, it's where a lot of misdiagnoses actually stem from in the medical field.
Oh, really?
Yeah. I mean, while hormones definitely play a role in the overall health of vulvar tissue, lichen sclerosus is fundamentally not a hormonal deficiency. It is a chronic, progressive, inflammatory skin disorder. So the core driver isn't a lack of estrogen. It is an immune system that is actively altering the structural integrity of the skin.
Okay, let's unpack this. So the immune system is the culprit here. But let's look at the ultimate consequence of that immune response. The question driving this deep dive today. Does this condition actually cause the labia minora to physically vanish?
The short answer is yes. It absolutely does.
Wow.
In the medical texts we reviewed, this phenomenon is referred to very clinically as a loss of architecture.
Loss of architecture. When I hear that, I picture like a wax figure left out in the hot sun.
That's a vivid image.
Yeah, where the distinct features, the ridges, the folds, they just sort of melt and pool together into this flat, featureless surface. Is that what's happening at a cellular level? Like, does the tissue just dissolve away?
The wax figure analogy is actually remarkably accurate for the visual result. But the biological mechanism is a process of intense chronic inflammation that leads to atrophy and fusion. So here's how the mechanics actually play out. As the disease progresses, chronic inflammation damages the subcutaneous tissue. That's, the critical layers just beneath the surface.
Right.
Over time, that underlying tissue wastes away or atrophies. And as it thins out, the labia minora, the inner lips of the vulva, they literally lose their structural support.
Because the foundation is gone.
Exactly. So they begin to adhere to the adjacent tissue, specifically the grooves next to them, which are called the interlabial sulci.
Wait, so they are essentially sticking to the surrounding skin because the tissue separating them has just wasted away.
Precisely. And as the tissue atrophies and adheres, it leads to a gradual effacement. The labia minora shrink, they flatten out, and they can completely resorb into the surrounding skin.
Giving the vulva a totally flat appearance.
Yes. The clinical term for this is midline fusion. And unfortunately, it doesn't just stop at the labia minora.
It spreads.
The clitoral hood can also become fused, literally sealing over the clitoris so that it becomes completely buried beneath a layer of rigid skin.
Gosh. So it's less like dissolving and more like an aggressive shrink wrapping.
Shrink wrapping is a great way to describe it.
Like the folds of the skin are inflamed.
Yeah.
And as the body tries to heal that persistent inflammation, it essentially glues everything down and smooths it over with scar tissue.
Yes. The body is caught in this relentless cycle of inflammation and faulty repair. Instead of laying down healthy, elastic tissue to heal the inflammation, the body lays down rigid scar tissue.
So the natural folds and contours are just pulled, taut, and fused together.
Right.
And the visual details in these clinical guidelines, they really paint a stark picture of how vulnerable this makes the skin. The sources consistently describe the affected areas as looking like cigarette paper.
Or wax paper, yeah.
Wax paper. It turns pale, ivory white, heavily wrinkled and incredibly fragile,
Because the skin completely loses its normal plumpness. It loses its elasticity and its vascularity, which is the blood flow that gives tissue its normal color.
which results in those pale, atrophic patches.
Exactly. It becomes so delicate that the slightest friction can cause it to tear, creating these really painful fissures.
You know, when you describe the body laying down rigid scar tissue over its own healthy anatomy,
No.
essentially erasing its own features, it sounds like a massive biological error.
It is a profound error,
I
yes.
mean, the immune system is supposed to defend our borders, not pave over them.
Hmm.
What exactly is misfiring in the immune system to cause this specific destruction?
Well, what's fascinating here is that to understand the misfire, we really have to look at what the immune system is actually targeting.
Okay.
While the absolute initial trigger for LS, like, say, a specific virus or some environmental factor, that remains unknown, but the overwhelming evidence points to an autoimmune response.
Meaning the body is mistakenly identifying its own structural components as a foreign threat.
Exactly. Specifically, researchers have found autoantibodies targeting something called extracellular matrix protein 1, or ECM1.
Extracellular matrix protein 1. Break that down for a second. If the skin is a building, is the extracellular matrix like the scaffolding holding the bricks together?
That's exactly it. The extracellular matrix is this complex network of proteins and molecules that surrounds your cells. It provides structural support, elasticity, and a framework for tissue repair.
Okay.
And ECM1 is a crucial protein within that scaffolding. It helps regulate collagen binding and basically keeps the skin thick and resilient.
So it's holding everything up.
Right. And in 60 to 80% of women with vulval LS, their immune system is producing antibodies that actively attack and dismantle the specific scaffolding protein.
Wow. So if the immune system destroys the scaffolding, the building of the skin just collapses.
It does.
The elasticity vanishes, the tissue thins out into that cigarette paper texture we talked about, and then the body panics and just pours rigid scar tissue over the wreckage to hold it together.
You've captured the exact pathology there. The destruction of ECM1 explains both the severe thinning of the skin and the subsequent rigid scarring that causes the architecture to fuse.
But wait, if this is a systemic autoimmune issue if these ECM1 antibodies are circulating everywhere in the bloodstream, why does the immune system launch this attack almost exclusively on the genitals?
That's a great question.
I mean, we have extracellular matrix proteins in the skin, on our faces, our arms, literally everywhere.
It's a critical distinction to make, actually. It doesn't strictly target the genitals, though that is by far the most common site.
Oh, it doesn't.
No, the clinical data shows that about 15 to 20% of patients do develop extragenital lesions. These can appear on the breasts, the wrists, the shoulders, or even the upper back.
So it can manifest on your shoulder.
Hmm.
But the vulva is clearly taking the brunt of the hit in the vast majority of cases. Why is that specific tissue so uniquely vulnerable to this autoimmune collapse?
Well, the vulvar skin is essentially a perfect storm of vulnerabilities for this specific condition. It has a very high density of specialized hormonal receptors. It exists in a naturally moist environment that can trap irritants. And crucially, it experiences a constant high degree of friction.
Friction just from existing, basically. Like walking, sitting down, the seams of your clothing.
Exactly. And the concept of friction brings us to one of the most fascinating and frankly frustrating medical phenomena detailed in the dermatological sources. It's called the Koebner phenomenon.
Ah, I flagged the Koebner phenomenon in the research notes. And it sounds like a literal biological trap. Walk us through how this mechanism actually works in the body.
The Koebner phenomenon occurs when physical trauma to the skin actually induces new lesions of a disease to form in that specific traumatized area.
Right.
It was actually first observed in psoriasis, but it is heavily present in lichen sclerosus. So here's how the trap works. The autoimmune attack on the ECM1 protein causes the skin to become highly inflamed, which triggers an intense, almost unbearable physical itch.
And obviously the natural human reflex is to scratch and itch.
Right. But when a patient scratches that itch, or even when tight clothing causes repetitive microfriction against the fragile skin, that microscopic trauma sends a distress signal to the immune system.
Okay.
The immune system rushes to the site of the scratch to heal the trauma. But because the immune system is faulty, it brings those ECM1 destroying antibodies right along with it.
Oh, wow. So the act of scratching the itch literally summons the disease to that exact spot. You are physically dragging the structural collapse across your own skin.
It is a devastating cycle. The physical trauma of scratching maps out the progression of the lesions. This is exactly why dermatologists often observe a very specific figure-of-8 pattern of pale, fused skin that forms around the vulva and extends downward to encircle the perianal area.
Because it follows the wiping or scratching motions.
The lesions follow the exact paths of friction and irritation, yes.
Here's where it gets really interesting, because that bridges the gap between what's happening microscopically with proteins and the sheer physical toll this takes on someone's daily life.
It's immense.
We're talking about an overwhelming itch, but the sources also detail severe dyspareunia, which is intensely painful intercourse. And it makes sense now. If the body has replaced elastic scaffolding with rigid scar tissue, the skin can't stretch, it just tears.
It tears, it bleeds, and then it heals by laying down even more rigid scar tissue, which further narrows the vaginal opening and compounds the problem over and over.
And it disrupts basic bodily functions, too.
Mm.
The medical texts note that women can experience severe urinary problems, like the spraying of urine,
Right.
purely because that midline fusion we discussed physically alters or even partially blocks the exit of the urethra.
And in children, it can actually cause severe constipation because the perianal lesions make it agonizingly painful to pass a bowel movement.
The functional impairment is just massive.
Yeah.
It alters how patients walk, how they use the restroom, and their intimate relationships.
Yeah. It affects every part of their lives.
So let me play devil's advocate for a moment here. We established early on that there's a huge spike in postmenopausal women. Now, genitourinary syndrome of menopause, or GSM, involves a massive drop in estrogen.
Yes, it does.
That also causes thinning skin, vaginal dryness, receding labia, and painful sex. So if a woman goes to her doctor with these symptoms, how does a doctor know she's looking at an autoimmune architectural collapse like LS and not just standard menopausal deflation?
This is a major source of delayed diagnosis, and the distinction really comes down to observing active destruction versus passive atrophy. You are totally right that GSM, driven by a lack of estrogen, causes the tissues to thin and recede,
Right.
but GSM does not cause the opaque wax paper white plaques. It does not cause the severe structural scarring, and it absolutely does not cause the labia minora to actively fuse to the surrounding skin or the clitoris to bury itself under scar tissue.
Okay, so GSM is passive shrinking from a lack of hormones, but LS is an active scarring destruction.
Yeah.
What about lichen planus, though? The sources group them together frequently.
Lichen planus is another inflammatory condition, yes. But the BSSVD guidelines give a very clear differentiator, and that is location. Lichen sclerosus essentially never involves the mucosa inside the vagina. It strictly affects the exterior skin.
Oh, okay.
If a doctor sees inflammatory involvement deep inside the vaginal canal, the diagnosis heavily points toward lichen planus.
That structural mapping makes sense, but distinguishing these conditions quickly is critical, right? Because the guidelines emphasize a complication that goes far beyond pain or losing physical anatomy.
Yes, they do.
There is a very real cancer risk attached to lichen sclerosus.
There is. If the chronic inflammation of LS is left completely unchecked, patients have a 4 to 6% lifetime risk of developing squamous cell carcinoma, which is a type of vulvar cancer.
4 to 6% might sound statistically small to some people, but if you're the patient sitting on the exam table, that is a terrifying number to carry with you. How does a skin condition turn into a malignancy?
It comes back to the cellular trauma we discussed. Chronic, unyielding inflammation causes cells to turn over and repair themselves rapidly and chaotically. Over time, this chaotic repair process can lead to cellular mutations.
Like precancerous changes.
Exactly. Dermatologists monitor LS patients closely for a specific precursor called differentiated VIN, or DVIN. This is a precancerous cellular change directly associated with the scarring of lichen sclerosus.
What happens if they find it?
If DVAN is spotted, it has to be surgically removed immediately because it has a very high probability of progressing directly into invasive squamous cell carcinoma.
Wow. So we have a disease that dismantles the body's scaffolding, fuses the architecture into flat scar tissue, feeds aggressively on the natural human reflex to scratch, and creates a pathway to cancer. That is a heavy reality.
It is incredibly heavy.
So what does this all mean? How do doctors even attempt to put out a fire that aggressive?
The absolute gold standard of treatment across all medical literature, from the Mayo Clinic to the European guidelines, is the immediate, disciplined use of ultra-potent topical corticosteroids. The most frequently prescribed is an ointment called clobetasol propionate.
I have to pause here because this feels like a glaring medical paradox to me.
How so?
Well, if you buy a mild hydrocortisone cream at the pharmacy for like a bug bite, the tube warns you not to use it for too long because steroids thin the skin.
Right.
We just spent 20 minutes explaining how lichen sclerosus turns the vulvar skin into fragile, tearing cigarette paper by destroying its structural scaffolding.
Wow.
Why are doctors prescribing the most potent skin-thinning steroids on Earth for skin that is already pathologically thin?
It is one of the most counterintuitive treatments in dermatology, I'll admit, but it comes down to understanding the mechanics of the greater threat. You are completely correct that long-term steroid use on healthy skin causes atrophy. But the skin of an LS patient is not healthy. It is under an active, hyperdestructive autoimmune attack. The inflammation is destroying the tissue far faster and far more permanently than a steroid ever could.
So you aren't thinning the skin further. You are essentially dropping a chemical hammer on the immune system to stop it from dismantling the ECM1 protein.
Precisely. You are using the ultra-potent steroid to paralyze the localized immune response. When you shut down the inflammation, the body stops attacking its own scaffolding.
And does it recover?
Surprisingly, once the attack stops, the skin actually has a chance to regenerate some of its normal thickness and elasticity.
But because it's an ultra-potent steroid, they have to
Yeah.
measure it carefully, right? They can't just use it endlessly.
Yes, precision is absolutely essential. The BSSVD guidelines give doctors and patients a very tangible metric to prevent steroid atrophy. A standard 30-gram tube of clobetasol should last a patient about 3 months during their initial intense treatment phase.
And after that,
It should last up to 6 months during their long-term step-down maintenance phase. If they are burning through a tube a month, they are over-applying and risking steroid-induced damage.
that's a very practical guardrail.
Hmm.
But we have to address the hardest truth in the sources we reviewed. We know the steroid stops the itch. We know it drastically lowers the cancer risk by stopping the cellular inflammation.
Yes.
But if a patient comes in and their labia minora has already resorbed or their clitoris is already buried under midline fusion, does the steroid cream rebuild that lost architecture?
No. And that is the most difficult conversation specialists have to navigate. Corticosteroids halt the progression of the disease, but they possess zero regenerative capabilities.
So it's gone.
Once the tissue has completely atrophied and fused into scar tissue, no amount of ointment will unfuse it or summon that anatomy back. The architectural loss, from a pharmacological standpoint, is permanent.
That means early diagnosis is the only true defense. If you catch it before the scaffolding collapses, you keep your anatomy. But for the patients who were misdiagnosed for years with menopause or yeast infections, and the fusion is already causing urinary blockages or making physical intimacy impossible, what are their options? Do surgeons just cut the scar tissue open?
In severe cases of functional impairment, surgery is utilized. Procedures like the division of adhesions mechanically separate the fused tissues to unbury the clitoris or widen the vaginal opening. But surgery in LS patients is incredibly fraught.
Because of the Kovner phenomenon.
Exactly. A surgical scalpel is the ultimate physical trauma to the skin. The body's immune system registers the surgical cuts, floods the area to heal them, and brings the autoimmune disease right back to the surgical site.
Oh, man. So it just heals back together.
The recurrence of fusion post-surgery is exceptionally high unless the patient is managed perfectly with aggressive steroids immediately after the operation.
It's relentless.
Yeah.
But looking at the very edge of the research stack, I saw some fascinating developments coming out of regenerative and aesthetic medicine clinics, like the Cadogan Clinic in London and Fox Valley Plastic Surgery.
Yes, the orthobiologics.
Right. They are looking beyond just cutting away the damage or suppressing the immune system. They're trying to actually rebuild the architecture.
Yes, this is where the horizon of treatment is really expanding. Because traditional medicine hits a wall at regeneration, these clinics are experimenting with utilizing the patient's own cellular biology to reverse the atrophy.
And the two major treatments they highlight are platelet-rich plasma, or PRP, and nanofat grafting. Break down the mechanics of this for us. How does injecting fat or plasma rebuild the missing scaffolding we talked about earlier?
It's all about cellular signaling.
Right.
Let's take nanofat grafting, for instance. The surgeon extracts a small amount of the patient's own fat, processes it into a liquid, and injects it directly into the scarred white vulvar tissue.
Okay.
That fat is incredibly dense with mesenchymal stem cells.
And stem cells are essentially blank slate cells, right?
Yes, and they act like microscopic construction managers. When you inject these stem cells into the atrophied tissue, they evaluate the damage. They begin secreting growth factors that stimulate a process called angiogenesis, which is the creation of brand new blood vessels.
So that brings blood flow and color back to that pale cigarette paper skin.
Exactly.
But what about the elasticity? What about the rigid scar tissue?
The growth factors in both the nanofat and the PRK also signal the local fibroblasts, the cells responsible for making scaffolding, to start producing fresh, highly elastic collagen and elastin rather than the rigid scar tissue the disease was creating.
Wow.
It literally instructs the tissue to remodel itself from the inside out.
That is incredible. They're essentially injecting a new set of blueprints into the damaged tissue to override the faulty autoimmune instructions.
Precisely. Now, it is crucial to note that this is still considered highly experimental for lichen sclerosus. The major dermatological guidelines do not yet endorse it as a primary treatment.
Right, it's still on the frontier.
But for patients who have suffered that devastating loss of architecture, these regenerative techniques represent the first real glimmer of hope that what was lost might actually be restored.
It really shows how far medical science has to push to outsmart our own biology.
Yeah.
So to pull all of this together for you listening, lichen sclerosus is a deeply impactful autoimmune condition where rogue antibodies destroy the structural scaffolding of the skin.
Yes.
And yes, answering our mission question, it can absolutely cause the labia minora to physically resorb, fusing the architecture of the vulva into flat scar tissue. But with early intervention using ultra-potent steroids, that destruction could be stopped in its tracks. And with the dawn of regenerative stem cell therapies, we might eventually find a way to rebuild what was taken.
If we connect this to the bigger picture, the sheer mechanics of this condition force us to look at the human body through a completely different lens.
How so?
We spend our entire lives viewing our physical anatomy as a fixed, permanent reality. We assume the architecture we are born with is the architecture we will keep. But seeing how a single rogue protein attack, exacerbated by the simple friction of tight clothing, can literally melt away and rewrite the structural boundaries of our own flesh, it reveals how fluid and temporary our physical selves really are.
And going back to the Koebner phenomenon we discussed earlier, if scratching and microtrauma can physically summon the autoimmune response to destroy the tissue, it implies that the sheer psychological willpower required to ignore an overwhelming physical itch could quite literally be the difference between preserving one's anatomy and losing it.
It really paints a picture of a profound mind-body battle playing out right on the surface of the skin. It urges us to consider the hidden, silent endurance of those living with chronic dermatological conditions.
That is a fascinating and somewhat unsettling perspective. It really highlights the concept of somatic malleability. We aren't carved out of stone. We are actively, continuously being built and rebuilt by microscopic cellular instructions every single second. We are. And if those instructions get scrambled, the physical self is quietly rewritten. It makes you realize that our anatomy isn't just a permanent structure we inhabit. It's an ongoing, highly delicate biological negotiation. Thank you for joining us on this deep dive into the resilient, complex, and ever-changing architecture of the human body. Keep learning, keep asking those great questions, and we'll catch you on the next one.